Okay, today we're going to start on Module E, Cardiovascular Alterations. We're going to start out with peripheral vascular alterations. Okay, so your suggested readings are in IGI, Chapter 38, pages 785 through 807. First of all, we're going to go over some anatomy and physiology of the vascular system. So let's look at arteries. Arteries basically are vessels that carry blood away from the heart towards the tissues. They're thick-walled structures with three layers: the intima, the media, and the adventitia. Okay, so smooth muscles encircle and control the diameter of the arteries in the body. Now your capillaries are arterioles branch into progressively smaller vessels, and then they form capillaries. Now, a single layer of epithelial cells that allow efficient delivery of nutrients, of oxygen into the tissues, and remove metabolic waste from the tissues. So that's what capillaries are. The tiny vessels that receive blood from the capillaries are venules, and these are the smallest veins that there are. Now your veins are basically the vessels that return blood to the heart. They're formed as capillaries organized into larger and larger vessels, and they're composed of the same layers as the arterioles and the arteries, but the layers are less defined. Now veins also have valves, and these allow the blood to move in only one direction and prevent any kind of backflow of the blood into the extremities. There's also innervation, and this is the sympathetic nervous system that acts as on the musculature of the veins to stimulate venoconstriction. Blocking of the sympathetic nervous system stimulates Blocking of the sympathetic nervous system stimulation permits venodilation. So, let's look at some factors that are going to affect the blood flow. Resistance, basically, is controlled by the diameter of the vessels. So when vasculature diameter increases, then peripheral resistance falls and blood flow increases. When the vasculature diameter decreases, then your peripheral resistance increases, and thereby it reduces the blood flow. Now, blood viscosity is basically the thickness of the blood, and this can be affected by changes in the proportions of the solids and liquids components of the blood. Capillary permeability affects blood viscosity also. If capillary permeability is altered, the amount and direction of the fluid movement changes and results in viscosity. And this, in turn, results in edema. So, peripheral circulation. Let's look at the peripheral vascular system. Basically, it describes the part of the systemic circulation that supplies the skin and extremities. It also helps to provide adequate perfusion, oxygenates and nourishes the body tissues. The peripheral vascular disease includes disorders that alter the natural blood flow throughout the arteries and veins of the peripheral circulation. Now, usually there is a much higher incidence of peripheral vascular disease in the lower extremities. It can be arterial or venous, but most often it's arterial. So this just shows problems on the arterial side, a diagram of the different places. So let's look at peripheral arterial disease of the extremities, or PAD. Basically, this is a chronic condition that deprives the lower extremities of oxygen and nutrients. It also can be caused by arterial sclerosis. That's the most common cause of altered blood flow, and that's basically caused by hardening of the arteries. It also is caused by buildup in the arteries. Some risk factors for this are going to be your smoking, diabetes mellitus, hyperlipidemia, hypertension, obesity, a family predisposition or a family history, and advancing age. Now, heart disease also can cause this because of decreased blood flow, the heart not being able to pump like it should. Now, some signs and symptoms. The first one we're going to talk about is intermittent claudication, and basically it's cramp-like pain in the extremity, constantly reproduced with the same degree of activity. So it's not pain that occurs like when you do a certain exercise or you move a certain way. It's pain that is always constantly there. So you're walking, say walking to the mailbox or walking to your car every day. It's the same degree of activity always causes this. Usually this is relieved by rest, so because the decreased metabolic needs of the muscles causes the pain to subside and be relieved. Now, sometimes there is ischemic rest pain, and that's usually in an advanced stage. This is a critical state, so a lot of times pain is worse at night. By placing the affected limb in a dependent position, this helps to relieve the pain. So some other signs and symptoms are going to be for arterial disease, the skin color is going to change. You're going to have pallor, or you're going to have rubor, redness, cyanosis, which is going to be blue or purple. Skin changes. You're going to have loss of hair. Now remember, with arterial, you're always going to have some of the signs and symptoms are going to be loss of hair to the affected limb, brittle nails, dry, scaling, atropic or shiny skin. So shiny appearance of skin is also a big sign and symptoms. Usually they're going to be sores that will not heal. When it's a severe disease, the pallor is going to be there even when the limb is elevated. There's going to be dependent rubor or reddish-blue discoloration of the extremities within 20 seconds to 2 minutes after placing them in a dependent position. When it's very severe, you're going to have gangrenous changes. And these are going to appear after prolonged ischemia, so tissue necrosis. So, we talked about in class about toes getting gangrenous, turning black, the tissue dying, because there's no blood flow to that tissue. Now, if you're following along, you can look at this slide, and it shows you some gangrenous toes and what they look like. Now, age-related changes, like we talked about, arterial sclerosis is stiffening of the vessel walls. This is caused by age. This affects the delivery of the oxygen and nutrients to the tissues that are compromised, and you end up with a buildup of waste in that tissue. And so that starts with damaging the tissue and killing the tissue. You're also going to have a decrease of hemoglobin, and this produces a decline in the oxygen carrying capacity of the blood. Slowing heart rate and decreased stroke volume also plays a factor. So for assessment, what you want to do is you're going to do the 6 P's, which is basically pulse. You want to look for any kind of these 6 P's basically determine the arterial flow or the tissue perfusion to those extremities. So you're going to check the pulse. You're going to look for pulselessness or no pulse in the extremity that's affected. Polydicothermia, which is what? Coolness felt at that site. So the skin is going to feel cold, cold temperature at that site. Your pain, whether they have pain in that extremity, the pallor, the color, and that's going to be related to the blood flow. So you don't have adequate blood flow, you're going to go from a pink to a pale color in that area. Paralysis and paresthesia suggests that the limb-threatening ischemia is occurring, and that's going to mandate prompt evaluation and consultation. So paralysis, they could not be able to move the limb. Paresthesia, basically the limb is going to have no feeling in it at all. So physical exam, like we talked about, there's going to be loss of hair on the lower extremities, usually below the knee. Your skin is going to be dry, scaly, could be dusky, pale, or molted. It's going to be shiny in appearance. Remember that. Loss of hair, shiny in appearance. Peripheral arterial disease. Toenails are going to be thickened. They're going to be brittle. With severe PAD, remember the extremity is going to be extremely cold, cyanotic, or darkened. Even when the extremity is elevated, you're going to have pallor. You're going to have rubor, and you may have muscle atrophy also. Once again, you're going to palpate the pulses in both legs. You're going to compare the strength of the pulses bilaterally. You're going to observe for any kind of ulcerations or the beginning of any kind of ulcers in these areas. Now, arterial ulcers, they're going to be painful. Usually these are going to develop on the toes or between the toes, or usually on the upper part of the foot. They're usually small, round, and they have well-defined borders. Now, some tests that they usually do to look for PAD, they're going to use ultrasound, usually going to Doppler, to determine how bad the disease is, to monitor any kind of changes in the blood flow associated with the vascular disease. It's basically where sound waves strike the vessel and reflect back. Pressure measurements such as plethysmography. It's a non-invasive study used to measure blood flow in the extremities. Arterial and venous flows are different. For arterial, they use 3 blood pressure cuffs applied and measure pulse waves of the extremity. Pressure readings are usually reduced to over a narrowed or occluded vessel. They also use an exercise treadmill. This is a non-invasive stress test. It's used to evaluate the patient's tolerance of activity. For this test, they will have to have a signed consent. Basically, the patient's going to walk on the treadmill with a continuous EKG and blood pressure monitoring. Now, angiography is basically used to confirm the diagnosis of PVD. It's also used to distinguish clot formation from a venous obstruction and to locate a suitable vessel for grafting. It is invasive and requires injection of dye into the vascular system that makes the vessel visible to X-ray. Some risks from this are going to be hemorrhaging, allergy to dye preps, thrombosis, and emboli. And then also the Allen test, and that's used also to determine adequate circulation to the hand. Now, non-surgical management of this, you're going to use positioning. So you're going to try to position, like we said, elevate the feet. But you don't want to do that above the heart level. Exercise, you want to teach these people not to lay around, but to exercise. You want to promote any kind of vasodilation you can. Usually these people are going to be on drug therapy, on vasodilators. You're going to try any kind of invasive non-surgical procedures. So like we talked about, the different tests that they're going to do to try to determine how bad the disease is, then they're going to use that type of stuff to for treatment, non-surgical treatment. Positioning, like we talked about, you want to elevate the feet, but not above the heart level. In severe cases, the patients are going to sleep with their legs in a dependent position. You want to make sure they don't cross their legs. You don't want to cut off more circulation. They need to avoid restrictive clothing, and you want to make sure you teach the patient to inspect their feet daily. So they want to check for any kind of ulcerations. Take care of that before, as it occurs, until you don't want it getting so bad that it gets gangrenous. So promoting exercise is going to build collateral circulation. You want to put people on an individualized exercise plan depending on their degree of activity beforehand. Also take into effect their physical health, their weight, and everything else. Certain patients should not exercise. They can do different exercises with their legs, moving their legs, moving their arms, range of motion exercises, that type of thing. But there's also certain patients you don't want to exercise. We talked about this in class. If somebody has a DVT, do you want that person moving that leg around? No, you don't. So to promote vasodilation, you want to keep that the affected limbs warm. Remember, we talked about you don't want to apply direct heat to the affected area, so you don't want to put anything hot on the affected area. But you want to keep those extremities warm, so you can put a warm blanket over them. You wouldn't want to put like a hot water bottle on anything, or a heating pad on an affected area. You want to drink adequate fluids. So drinking fluids promotes venous stasis, promotes venous flow, promotes hydration, and hopefully affects the vasodilation and gets the blood flowing in those areas. You want to avoid caffeine, nicotine, any kind of emotional stress. You also want to teach them complete abstinence from smoking or chewing tobacco. Usually this is the most effective method of preventing any kind of vasoconstriction. So some drug therapy that they use. Trentol, which basically improves circulation by increasing red blood cell flexibility. It also decreases blood viscosity by inhibiting platelet aggression. You usually take that with food. It may cause dizziness initially, so you need to be careful with that. Pletal is an antiplatelet agent or a platelet inhibitor. It is a vasodilator, so it lessens claudication or claudication. You want to make sure they take that on an empty stomach. They may take it for several weeks before the therapy actually gets to a therapeutic level. There is drug interactions with that. You want to watch for Prozac, Zoloft, any kind of antifungals, erythromycin, grapefruit juice. All those can affect Pletal. You also are going to use aspirin, Plavix, any kind of antiplatelet drugs that prevents any kind of arterial thrombosis. Now, the effect lasts about 7 to 10 days, and it is irreversible. Now, some things you want to know about before you prescribe any of these medications. You want to make sure to know about any kind of herbal products they're on: ginkgo biloba, feverfew, garlic. These can suppress platelet aggregation and can increase the risk of bleeding in patients that are receiving any kind of antiplatelet drugs. Okay, so we're also going to talk about percutaneous transluminal angioplasty. Basically, it's where the arteries are dilated with a balloon catheter to relieve any kind of arterial occlusion. They can put a stent in. It's usually used to keep the vessel patent. It's only used on certain vessels only. So it's good for poor surgical candidates who can't go through a graft. The problem with it is usually reocclusion will occur within 3 to 5 years. Some of them sometimes even within 1 year. The common is usually going to be used on the external iliac vein, arteries. Is usually where this method is used. So some other surgical management: arterial revascularization. Usually Alright, sorry about that. Anyway, severe rest pain and claudication. Usually that requires surgical management. There's 2 different types. They're classified as inflow and outflow. So let's look at those. Your inflow basically bypasses arterial occlusions above the superficial femoral arteries. It is usually they're done aortoiliac, aortofemoral, or axillofemoral bypasses. Now, there's less chance of any kind of reocclusion or post-op ischemia when you do an inflow. The graft is autogenous, so it's going to be from the saphenous, celiac, or basilic arm veins. Sometimes they use synthetic grafts, and these usually will work okay. Now, the outflow usually bypasses arterial occlusions at or below the superficial femoral arteries. It's going to be your femoral popliteal or femorotibial bypasses. There is a greater chance of reocclusion or post-op ischemia with these. A lot of these are not long enough to use, so they have to use synthetic grafts, and usually these aren't as adequate as using from their own body. A lot of times they have to use composite grafts that are made from multiple vein segments to graft these in. And this kind of shows you a diagram of what these look like, the different areas. So post-op care for these patients that have went through the grafts, you're going to teach them to deep breathe every 1 to 2 hours. You want them to use their incentive spirometer while awake as often as possible to expand their lungs. The first day, usually a post-op, you're going to keep them NPO. The OR or PACU nurse is going to mark the dorsal pedis and posterior tibialis pulse. And a lot of times with these patients, you're going to have to use a Doppler to hear those pulses or to feel those pulses. You won't be able to palpate them. You're going to have to use a Doppler to find them. You want to monitor their blood pressure. So if you have a immediate decrease in blood pressure, you need to check for any kind of hemorrhaging or leaking. You don't want these patients bending their hips or their knees. So you want to keep them on bed rest 18 to 24 hours after surgery. You want to try to keep them as still as possible. They don't need to be getting up. They don't need to be moving around too much in the bed, twisting, turning, trying to push with their legs and things. Also, you're going to assess for pain. You want to know what type of pain it is, where it's located. You're going to use a sterile technique when you're providing any kind of incisional care, because you want to make sure you assess for infection. You want to keep that area clean and away from any kind of infection. So you're going to notify the surgeon if you see any kind of signs of infection in that area. You're going to check the extremities about every 15 minutes for an hour, and then you're going to check them hourly. And you want to compare both legs. So you're going to compare the pulses in both legs. You're going to compare the color, the coolness, the temperature, all that stuff. Now, home care assessment. If you got a patient that's got PVD and you're taking care of they're at home, you want to assess any kind of tissue perfusion to the affected extremities. You want to assess their adherence to the therapeutic regime. So are they taking their medications? Are they doing what they're supposed to be doing? You want to assess their ability to manage the wound care and prevent any kind of further injury. So you're going to teach them. You also want to assess whether they need help. Do they need home health coming out and helping them with that? You're going to assess their coping ability of them and their family. So how well are they coping with this? Do they understand the disease? Do they understand all the effects that it has and all the things that need to be done? And you're going to assess their home environment. Like we said, some homes are going to be beneficial for the patient. Some are going to be non-beneficial. So you're going to have to teach the patient, if they have animals or they have other things like we talked about in class going on. You want to keep that so if they get sores, they don't get infected. So foot care for patients with PVD. What you want to make sure is they keep their feet clean and dry. They need to wear comfortable fitting shoes. They need to keep their toenails clean and filed and cut straight across. You don't want them to get any kind of infection in their nails. You want to apply lubricating lotion to the feet. Now, unless they have cracks and are bleeding, you're not going to use usually any kind of ointment. You just want to put lotion on their feet. You want to avoid any kind of constricting clothing. You don't want to cut off any circulation more than it already is, and you're going to avoid any kind of extended pressure on the feet or ankles. So interventions, you want them to exercise gradually, increase slowly, encourage it as prescribed. This is going to help you develop their collateral circulation. Position, you want to make sure they elevate their feet at rest, but not above the heart. They need to avoid crossing their legs. This is going to reduce swelling, but extreme elevations, you don't want to put them in extreme elevations because it's going to slow the arterial blood flow to the feet. Now you want them to avoid any kind of exposure to cold. You want them to wear socks and insulated shoes at all times. This is going to promote vasoconstriction. Vasodilation. It's going to promote vasodilation. The cold will promote vasoconstriction, so you want to do the opposite. You never want to apply direct heat. You want to use soaps and lotions that are recommended by the medical provider, and you want to inspect the feet daily. Like we said, applying direct heat, they're going to have decreased sensation, so you do not want them to burn or get a burn. Now, acute arterial occlusions, these are emboluses that lodge in the blood vessels. They usually tend to lodge at bifurcations. It's usually a sudden, severe onset of pain, pulselessness, pallor, paresthesia, paralysis, and polytothermia. Like we said, the symptoms tend to be more intermediate and severe because there's not enough time for collateral circulation to develop. Any kind of sensory loss is going to require urgent treatment. Most likely it's caused by an emboli. Now this is an emergent situation, so they're going to be put on anticoagulants, thrombolytics, or they might have an embolectomy. Remember, time is of the essence for these. Now, usually these people have had acute MI or AFib within the preceding weeks, so you need to be careful with those patients. These also can lead to renal failure or possible compartment syndrome. So these, like we said, they're urgent situations that have to be treated immediately. So Buerger's disease or thromboangiitis obliterans is usually caused, number one cause is usually smokers. It's inflammation with thrombolysis, or with the thrombosis. Usually it's believed to be of an autoimmune origin. It's reoccurring inflammation of the intermediate and small arteries, usually on a distal, upper or lower limb. There's going to be coolness, numbness, or tingling in that affected limb. It usually occurs to men between the ages of 20 to 35 years old. Like we said, heavy tobacco use is usually a big cause of this. They could have superficial thrombophlebitis. They're going to have pain in that area. It's going to be exacerbated by cold, nicotine, and stress. So they're going to have diminished pulses in those distal extremities. Usually they're going to be red or rubor in a dependent position, and they can develop ulcers. So some things you're going to do smoking cessation. You want to try to improve the circulation to those areas. Okay, you're going to monitor their pulses. You want to try to prevent any kind of injury to those extremities, and you're also going to start them usually on a medication therapy. So you want some vasodilation going on to try to increase the blood flow. There's no cure. This is just a picture of it. There's no cure for Buerger's disease. The goal of treatment is to control the symptoms. So you want to try to control the symptoms. You're not going to cure it. Now, arterial ulcers are usually located on the feet and often occur on the heels, tips of toes, between the toes, or where the toes rub against each other, or anywhere else the bones may protrude and rub against the bed sheets, socks, or shoes. Now, arterial ulcers also commonly occur in the nail bed if the toenail cuts into the skin, or if the patient has a recent aggressive toenail trimming or an ingrown toenail removed. Now, the base of an arterial or ischemic ulcer usually doesn't bleed. It usually has yellow, brown, gray, or blackened in color. The borders surrounding the skin usually appear as though they've been punched out. If irritation or infection are present, then there may not be swelling or redness around the ulcer base. There may also be redness on the entire foot when the leg is dangled. Now, this redness is often going to turn into a pale white, yellow color when the leg is elevated. Now, typically arterial ulcers are very painful, especially at night. So the patient may instinctively dangle his or her foot over the side of the bed to relieve the pain. The patient usually has prior knowledge of poor circulation in their legs. and may have another accompanying disorder, such as the ones we've already talked about in this section. So, let's look at another disease, Raynaud's disease and Raynaud's phenomenon. Raynaud's disease is basically vasospasms of the arterioles and the arteries in the upper and lower extremities. Now, Raynaud's phenomenon, their signs and symptoms are identical to the disease, but it's associated with connective tissue or collagen vascular disease. So, causes for Raynaud's are going to be coldness, pain, pallor of the fingertips or toes. Typically, it's brought on by cold, nicotine, or exposure to stress. Now, remember we talked about they're going to have a sequence of change in colors. So, it's going to go from white, blue to red in color. If you look at the hands on this slide, you can see the different colors. Now, like we said, Raynaud's is caused by constriction of the vessels that decreases the blood flow to the fingers, causing them to turn pale, or to the toes. This just shows a cutaway of a vessel. So, treatment, you're going to try to prevent the pain and promote vasodilation. You're going to use calcium channel blockers, transdermal nitroglycerin, endothelin receptor antagonists such as bostatin. They may also go in and do a sympathectomy, which basically they're going to deaden the nerves, or they're going to sever the nerves to the sympathetic nervous system. So what you want to do with Raynaud's is you're going to teach the patient to avoid the stimuli that cause the vasoconstriction. You're going to teach them smoking cessation, to avoid caffeine. Oftentimes these people are going to wear mittens even in summertime. They need to have a medical alert bracelet on so that they know they're not supposed to receive any kind of vasoconstrictors, because what's going to happen is it's going to cut off all circulation to those hands, and they're going to rot and die. You want to place the affected part in warm water, or use a hair dryer on a low. You don't want to put anything on it that's going to, like, remember that you don't want to put immediate heat on the affected area, okay? So you're going to put warmth, not heat. Now, Berger's is usually a steadily cutting off of the nerve flow, where Raynaud's is basically an intermittent blood flow cut off. So like we said with Raynaud's, you want to avoid any kind of stimuli such as cold, nicotine, or stress. During the winter, they need to stay indoors, wear layers of clothing, hats, mittens. They want to insulate themselves well, so they want to wear layers of clothing. Like we said, extra precautions in the wintertime. They want to avoid touching any kind of cold objects, avoid injury to those areas that they're having problems with. You're going to teach them stress management is a big thing to try to work with Raynaud's, so stress management. You're also going to use calcium channel blockers as medication therapy, so Procardia, Adalat. This blocks calcium channels in the vascular smooth muscle and promotes vasodilation. Some things you need to look for with these medications are flushing, dizziness, headache, peripheral edema, gingival hyperplasia, and hypotension. You're also going to see them use sildenafil and also nitroglycerin patches. Now, things you got to watch out is postural hypotension, okay, with these medications. Now, let's look at some problems from the venous side. Peripheral vascular disease is basically disorders of the arteries and veins. Describes a wide variety of conditions. So arterial disease is usually occlusive, aneurysmal, or vasospastic. Spastic usually occurs in the neck, abdomen, and extremities. Now, the venous part of the disease usually occurs because of a thrombosis or chronic insufficiency of blood flow. Primarily, it's in the lower extremities. Now, risk factors for this are going to be vascular disease. For this vascular disease are going to be increased age. We talked about arteriosclerosis, heredity, smoking, obesity, any kind of physical inactivity, hypertension, and diabetes. Also remember that PVD can lead to functional impairment. So it can cause mental changes as well as physical changes. So peripheral venous flow, basically to function properly, veins must be patent. They have to have competent valves. They also have to have the assistance of surrounding muscle beds to help pump the blood towards the heart. So some problems that can occur if this isn't functioning properly, you're going to have clot formation that could cause a pulmonary emboli, defective valves, you're going to have venous insufficiency and varicose veins. So some definitions we'll go over before we start this. A bruit is basically a sound associated with turbulent, fast-moving blood flow. An embolus is going to be a foreign substance carried through the bloodstream. Intermittent claudication is basically going to be pain that occurs with exercise but is relieved with rest. And a thrombus is going to be a blood clot. You need to know these terms. So some things we're going to look at: varicose veins, venous thrombosis, thrombophlebitis, DVT or deep vein thrombosis, pulmonary embolism, and a chronic venous insufficiency. So first thing we're going to look at is varicose veins. Basically the definition is dilated tortuous veins are most common in the saphenous vein system. Now, some contributing factors are going to be congenital weakness in the vein structure, obesity, pregnancy, thrombosis, tumors, or occupations that require long periods of standing. So your factory workers, unfortunately nurses, anybody that stands on their feet for long periods of time are going to be susceptible to varicose veins. Signs and symptoms are basically going to be aching pain when they're standing or walking. Sometimes they're going to have a heavy feeling in the affected legs, edema, and night cramps. Diagnosis is usually based on appearance. Can also use a Doppler ultrasound or the Trendelenburg test. Now, usually the onset is gradual, but the condition is progressive. Most of the signs and symptoms are going to be minimal, except for they're going to be oversized, discolored, purplish, and tortuous veins in appearance. Alright, so varicose veins usually are going to be abnormally dilated, tortuous, superficial. They're going to have incompetent valves. It could be caused by incompetent valves. Long periods of standing, heredity, pregnancy, all these things contribute to that. Prevention, basically you want to avoid activities that cause venous stasis. So you want to promote regular exercise. Treatment surgically, they could do stripping, which is basically, if they do that, they're going to be on bed rest for 24 hours with compression stockings continuously for 1 week. These patients, you want to monitor their groin and leg for any kind of bleeding or hemorrhaging. You're also going to monitor for sensation. So pins and needles in the affected leg, that means they have nerve damage. They also could have sclerotherapy or laser ablation. Now, conservative measures used to treat whenever possible. Non-surgical treatment, basically you're going to avoid any kind of restrictive clothing, avoid any kind of prolonged sitting or standing, crossing the legs or knees. Try to avoid any kind of injury to the compromised areas. You're going to encourage weight reduction. Support stockings can also, you're going to recommend support stockings. Now, sclerotherapy is basically hardening or induration of the vein. So you're going to inject a sclerosing agent, usually a hypertonic saline, about 20% or 23%. Surgical ligation basically involves isolating the faulty valves and removing them, but leaving the rest of the vein. And then stripping, which involves removing sections of the veins. So nursing care, basically you're going to teach self-care and prevention is what you want to do. If it's post-op, your interventions, you're going to try to improve their physical activity tolerance. You want to manage their pain, but the most important part is prevention. So patient education. You want to avoid long periods of standing or sitting, tight clothing. You want to encourage daily walking, loose clothing, ideal body weight. You want to promote any kind of stockings. If they're going to be on their feet for a long period of time, you want them to elevate their extremities when possible. You're also going to have them use non-prescription analgesics and frequent position changes, usually to control pain. So varicose veins, this just goes to show you the different places that they usually are. All right, thrombophlebitis, basically signs and symptoms are going to be it's going to be palpable, firm, subcutaneous tissue, cord-like vein. It's going to be tender, red and warm, may have edema to the area. Most commonly it's caused by IV therapy or IV infiltration. Treatment is going to be immediate removal of the IV catheter, elevation of the extremity to promote venous return, and a warm, moist heat to relieve the pain and treat inflammation. Now, you want to keep checking those IVs, okay? So this is part of your assessment you need to be completing every 4 hours. No matter what the disease process, you want to assess the IV site regularly. Let's look at venous thrombosis. So some terms you're going to need to know. Phlebitis is basically inflammation of the vein wall. Thrombophlebitis is a clot formed at the site of the inflammation within the vein. Phylothrombitis is basically presence of a thrombus in a vein. Deep vein thrombosis is presence of a clot in a deep vein rather than a superficial one. Now with DVT veins, the DVT veins usually are involved. Complication of a DVT is going to be pulmonary embolus. So, risk factors for getting a DVT: prolonged bed rest. So, surgery for people older than 40 years of age is a big risk factor. Any kind of leg trauma resulting in immobilization or cast or traction. So a lot of older adults that are having knee surgeries or hip replacement, knee replacement surgeries are going to be at great risk. Any kind of previous venous insufficiency, as well as obesity. Also the use of oral contraceptives. These are all going to cause some type of thrombosis. They're going to put them at risk for thrombosis. Now, the three important factors in the etiology of venous thrombosis is venous stasis, which is dysfunctional valves or weak muscles, endothelial damage, which is damage to the surface of the vein, or hypocoagulability of the blood. Now, venous stasis, a lot of times that's caused by advanced age. It can be also caused by AFib, CHF, obesity, orthosurgery, usually in the lower extremities, postpartum patients or pregnancy patients, anybody that's on prolonged immobility. So people on a long trip, they've been sitting in a car for a long period of time, on bed rest, spinal cord injuries, CVAs, varicose veins. Endothelial damage is usually abdominal or after abdominal or pelvic surgery. Can be caused by hip or leg fractures. Usually it has a diagnosis of DVT. Can also be caused by indwelling femoral venal catheter, as well as IV drug abuse and trauma. Hypocoagulability of the blood. Usually this is going to be caused by smoking, dehydration, malnutrition, severe anemia, sepsis, any kind of malignancies, especially breast, brain, hepatic, pancreatic, or GI. Signs and symptoms of each may vary a little bit slightly. There also may be no signs and symptoms at all. Generally, there may be edema, heat and redness and swelling at the site. They're going to have a positive Homan sign, and their superficial veins are going to be more prominent. Now, with deep vein, your signs and symptoms are going to be edema, warmth, and tenderness at the area of compromise. They're going to have a positive Homan sign. Their superficial vessels are going to have pain, redness, warmth, and tenderness at the affected site. So medical diagnosis and treatment of venous thrombosis, they're going to do usually a venography, where they're going to look at the vein, a sonogram of the vein, a Doppler ultrasound, a duplex ultrasonography. They're also going to do a lung scan, pulmonary angiogram, or a spiral CT scan if there's a pulmonary embolism suspected. Treatment for a venous thrombosis, medical and surgical treatment is going to be usually anticoagulant or thrombolytic therapy, or both. You're going to do patient teaching about the disease. You're going to do an ongoing assessment of any pulmonary emboli. These patients are going to be on bed rest. They're usually going to have elevation of the extremity, warm, moist soaks to the affected area. Anti-embolism hose are going to be put on the patient. Now, if they have to have surgery, it's considered when a patient can't receive anticoagulants or thrombolytic therapy, or when there's a high possibility of a pulmonary emboli. So surgery is considered in these cases. Now, if they're getting anticoagulant or thrombolytic therapy, or both, teaching is a main priority. Nursing, basically you're going to keep assessing ongoing for pulmonary embolus. In nursing care, you want to maintain skin integrity. You're going to try to decrease their discomfort. Like I said, education is a big thing. You let them have activity as permitted to try to improve the tissue perfusion, and you're going to monitor continually, like I said, for a PE. Now, some signs and symptoms, like we said, they may have no signs and symptoms, or they could have leg edema, unilateral leg edema, extremity pain, warm skin, erythema, and sometimes a fever greater than 100.4. Usually have calf tenderness on palpation. Not palpitation. Positive Homan sign is usually a classic sign, but it only appears in about 10% of DVT patients. Pulmonary embolus is a severe complication of DVTs. Okay, so remember that. So treatment, you want to do prevention, so you're going to do early mobilization, TED hose, SCDs. Bed rest patients, you need to change the position, dorsiflex the foot and ankles every 2 to 4 hours. This is prevention. You want them up to the chair for meals and to ambulate 3 times a day. Usually you're going to use TED stockings. Remember, proper size is important. SCDs, sequential compression devices, usually going to be used in surgical cases in high-risk patients. Surgical therapy, they might do a thrombolectomy, which is rarely done for leg DVT, commonly done on AVG for dialysis. Now, IVC filter, which is an inferior vena cava filter. A lot of times these are put in. These are a femoral precutaneous approach. Basically, they're employed into to catch any further clots and to prevent any kind of CVA, PEs, that sort of thing. Now, medications we're going to discuss on the next few slides are going to be your heparin, Lovenox, Fragmin, Coumadin. All these things are anticoagulants. So pulmonary emboli is basically a blockage of the pulmonary arteries by thrombosis, fat, or air emboli or tissue, tumor tissue. Most of these arise from a fragmented DVT. They're usually large mobile clots that circulate until they lodge in a narrow arterial circulatory system. Symptoms are based on the size of the clot, and most common are you're going to have anxiety and sudden onset of unexplained dyspnea, tachypnea, or tachycardia. Usually they're going to have a cough or pleuritic chest pain, hemoptysis, crackles, fever, sudden change in mental status from hypoxemia. With a massive PE, you're going to have a sudden collapse with shock, pallor, severe dyspnea, crushing chest pain. Death usually occurs in 60% of these patients with a massive PE. So management of a PE, you want to have oxygen available immediately. You're going to establish IV or make sure your IV is patent. You want to get ABGs, so you're going to check their blood gases and see how well they're oxygenating. Usually they're going to do a CT angiogram to rule out PE or to rule in a PE. They may start them on a dobutamine drip, which dilates the pulmonary vessels. you're also going to try to relieve the pain and anxiety. So they're going to give them pain medications or anxiety medications. So these are just some filters, green field filters, umbrella filters that they use to prevent any kind of pulmonary emboli. And this just shows the position of the, and we talked about that earlier, about the filters. This is just another example that shows you. So treatment for DVTs, basically the aim is you want to prevent the thrombus from extending. You want to prevent any kind of fragmenting to prevent any pulmonary emboli. You want to prevent reoccurrence. So interventions you're going to do for DVTs is basically you're going to put them on bed rest, follow prescribed activity. You're going to elevate the affected, but not above the heart. You don't want to massage the areas. You want to put compression stockings as prescribed. And you want to monitor for signs and symptoms of a PE. So signs and symptoms, sudden onset of shortness of breath, chest pain, impending doom. Remember, with any kind of anticoagulation therapy, you're not going to dissolve the clot. You're going to keep it from extending. So let's look at heparin, anticoagulant. Heparin, usually the effects begin immediately. Their half-life is about 1.5 hours. Basically, heparin inhibits clot formation. It can be given subcutaneous or IV, but not given by mouth. Helps prevent the extension of existing thrombus, but it is not going to dissolve it. So it's going to keep it from getting bigger, but it's not going to dissolve it. It also acts rapidly in proportion to the concentration in the blood. So labs, you want to get a APTT, which is an activated partial thromboplasm time. This is going to be monitored throughout the therapy as a guide to adjust the dosage of the heparin that they're getting. And usually every hospital has a heparin protocol that they go by. You're also going to check a CBC, so you want to check their platelet count. You're also going to get the APTT prior to starting. Now, some problems that can occur, you could end up with bleeding, you could end up with heparin-induced thrombocytopenia. So, if you have complications with heparin, the antidote is going to be protamine sulfate. It neutralizes the heparin molecule immediately, lasts about 2 hours. You're going to push about 20 milligrams a minute, 50 milligrams in 10 minutes. And it's a slow IV push. Now, some signs and symptoms that you're going to look for with heparin therapy is going to be bleeding, blood in the urine, nosebleeds, bruising, bleeding gums. For thrombocytopenia, basically for the first 5 days, you're going to look for more clots. Mild cases, you're going to have some people that go through heparin withdrawal. So that has to be monitored closely. Biggest thing I want you to remember is protamine sulfate is the antidote for heparin. Okay? Some other anticoagulants is your low molecular weight heparin. That's going to be stuff like your Lovenox or Fragmin. This is done by a subcutaneous route only, 1 or 2 injections a day. It prevents the extension of a thrombus. This is usually associated with fewer bleeding complications than heparin. No APTT needs to be monitored, and it can be administered at home. Now, the big thing to remember with Lovenox or Fragmin is that the syringe is going to come pre-filled and it's going to have a airlock in it. You do not want to get rid of that airlock. Okay, the airlock is used to promote all the medication getting into their system. So the airlock is used to make sure that all the medication gets into their system. So you do not want to get rid of that airlock. It is, like we said, given sub-Q, 1 to 2 times a day, and it has fewer bleeding complications. Now, your warfarin or your Coumadin is basically an antagonist of vitamin K. It interferes with the clotting factor development. When first starting Coumadin, it takes about 3 to 4 days before it becomes therapeutic. And basically, Coumadin is rat poison, is what it is. Its half-life is usually 1.5 to 2 days. With this kind of therapy, you're going to monitor the PT, the prothrombin time, and also the INR, which is the International Normalized Ratio. So your INR is usually going to be between 2 and 3, and that's appropriate for most patients. Now, long-term therapy, they're going to have a PT INR measured at prescribed intervals. Patient education, you're going to have them have a medical alert bracelet or ID with blood thinner dose on it. You do not want them to take other medications without approval from their doctor. So that includes over-the-counter medications, herbal medication. You want them to report any kind of immediate signs that they're having bleeding problems immediately to their doctor, or having any problems with their Coumadin. You also want them to stay away from foods, or stay away from foods high in vitamin K, or eat them in moderation. So these are going to be things like your green leafy vegetables, cauliflower, broccoli, Brussels sprouts, cereals, cow's milk, egg yolks, meats such as pig and beef liver, your peas, potatoes, string beans, yogurt, all those, they need to do those in moderation, not eat a lot of those. Now, Coumadin therapy, some signs and symptoms to report: if they get faintness or dizziness or increased weakness. Also, birth control pills can decrease the effect of Coumadin. Severe headaches and abdominal pain. They could have reddish or brown urine, red or black stool, some type of bleeding that doesn't stop, bruises that enlarge, nosebleeds, unusual bleeding. You want them to avoid any kind of injury, so use an electric razor, soft toothbrush, no alcohol, because that makes the blood even thinner. If they have a suspected pregnancy, they need to automatically call their doctor. Now, the antidote for Coumadin is going to be your aquamethaton, which is vitamin K. Now, if a patient needs surgery, a lot of times they're going to stop the Coumadin therapy ahead of time, usually give them fresh frozen plasma or blood products to try to coagulate their blood a little bit more. Now let's look at PVD. Basically, is chronic venous insufficiency. Your chronic venous insufficiency is going to be caused by destruction of the valves, allowing retrograde blood to flow back through the venous blood. Their signs and symptoms are going to be persistent edema in the lower legs. So remember that. Edema in the lower legs, pain, increased pigmentation, so status dermatitis, secondary varicosities, cyanosis, stasis ulcers also can form. Now, the leg ulcers may be caused by chronic venous insufficiency. They're usually common in the elderly, and it's usually caused by vein and valve incompetence. Now, complications are going to be infection and cellulitis. Peripheral pulses are going to be a lot of times difficult to palpate due to the edema. Diagnosis is usually done by a physical exam or a venous Doppler study or duplex scans. So some of your signs and symptoms, like we talked about, persistent edema in the lower legs, especially the feet and ankles. Sometimes the feet and ankles are going to be cyanotic even when they're in a dependent position. The skin temperature is going to be warm. There's going to be sometimes a heaviness or dull ache in the calf or thigh. Now, your venous insufficiency, prolonged venous hypertension, a lot of times causes this. It stretches the veins and damages the valves. This can lead to ulcer swelling and cellulitis. Status dermatitis is a brown discoloration along the ankles and extending up the calf. Usually this is long-standing, so it stays that way. You're going to have people that have that brown skin, brown discoloration on their lower legs. Usually it's dry, cracked, and itchy. Sometimes they get ulcerations, and then this is caused by small skin veins rupturing. So treatment for chronic venous insufficiency are going to be compression hose, so compression stockings, moist dressings, additional nutritional, looking at their nutritional status, antibiotics, and sometimes surgery. Now, compression hose we talked about, you're going to use elastic or compression stockings, pneumatic devices. If the patient has an ulcer, they're going to have a special dressing, systemic antibiotics, or topical debriding agents such as lace or uniboots. Sometimes they'll be on hyperbaric oxygen therapy, and this is compression to promote venous return. Now, nutrition-wise, you want to increase their protein, especially their vitamins A and C and zinc. This helps to encourage healing of the ulcers. The biggest thing you want to do is you want to assess for signs and symptoms of infection. So look for any kind of pus drainage, increase in pain or erythema in those areas. If they do have wounds, you want to culture those wounds and send them off so they can be treated with the correct antibiotic. Surgery, a lot of times they're going to do debridement on those areas. Prevention-wise, what you want to do is you want to try to get those people to avoid trauma to those areas, compression, teach them compression, skin care, limb positioning, assessment for people with CVI. You're going to inspect the lower extremities for any kind of rubor or stasis dermatitis. You're going to palpate the skin temperature and determine the presence of any kind of pain in the affected extremity. Venous insufficiency, a lot of times it may lead to venous ulceration, so you want to elevate the legs at least 15 to 30 minutes every 2 hours. You want those to be above the heart when supine. Now, compression stockings, like we said before getting out of bed, you want to make sure they keep clean stockings on. Okay. You want to avoid any kind of prolonged sitting, standing, or restrictive clothing or leg crossing. And this is just showing you what a venous ulcer looks like. So let's look at the difference between venous and arterial ulcers. Okay, venous ulcers are going to be usually on the inner outer ankle or anterior tibia. They're going to have an irregular border, so remember that, an irregular border. They're going to be superficial. They're going to have a pink wound bed, uneven edges, pain may or may not be present, and no claudication or rest pain. Now, arterial, usually going to be on the tips of the toes, the toe webs, or the heels. They're going to be circular and they're going to have even edges. Okay, they're going to have an even border or circular border. They're going to be deep. They're going to be pale to black. They could be dry and gangrenous. Usually are very painful, and they're going to have rest pain is usually present at these times. And here's the difference between the two. So venous ulcer treatment, like we said, compression. You're going to keep a moist dressing on it if they have an ulceration. Here's just another thing that talks about the difference between the arterial and venous stasis ulcers. You need to be familiar with both of those. Now we're going to look at aneurysms. And this basically shows what the formation of an aneurysm. Now, the different types of aneurysms, most are usually below the renal arteries. The aortic aneurysm may involve the aortic arch, the thoracic or abdominal aorta. Now, the thoracic usually has no symptoms, can cause deep, diffuse chest pain, hoarseness, dysphagia, distended neck veins, and edema of the head and arms. Abdominal usually has no signs or symptoms, but on exam there's usually a pulsatile mass, bruit, on the abdomen. They also could have signs and symptoms of abdominal or back pain. Now remember too, there's such a thing as called a false aneurysm, and that is basically a complete rupture of the vessel wall with bleeding into the surrounding areas. So this is basically what a normal aorta looks like. And here's an aorta that's had arteriosclerosis. The plaques that have gone and had multiple thrombus. So here's a example of atherosclerotic aneurysm in the aorta, which is the large bulge that appears in between, right above the aortic bifurcation. Now, these aneurysms are prone to rupture when they reach about 6 to 7 centimeters in size. They can be felt on physical examination as a pulsable mass in the abdomen. Most of these aneurysms are conveniently located below the renal arteries. So surgical resection can be performed with placement of a graft. So some things to look for with an aneurysm rupture: severe back pain or abdominal, groin or periumbilical pain. You're going to have flank ecchymosis, hypovolemic shock. That's going to have paleness and weakness, tachycardia, hypotension, pale and clammy skin, decreased sensorum, and abdominal tenderness on palpation. Now, a posterior rupture is going to be tamponade by surrounding structures in the retroperitoneal space, and this is going to prevent exsanguination. So it's going to prevent the blood from escaping too rapidly. If it's an anterior rupture, most don't survive to the hospital. Simultaneous resection and surgical repair are needed immediately, but most of these people do not survive. An aortic dissection basically is a tear in the intimal lining of the arterial wall, creating a false lumen. About 90% mortality rate in ascending aortic dissection. So signs and symptoms are going to be sudden severe pain in the anterior chest, interscapular pain radiating down through the spine to the abdomen or legs. Can be described as a tearing or a ripping pain. You're going to have a difference in blood pressure between the arms. So this can include the major arteries. And here's just a picture of an aortic dissection. So for AAA repair, aortic aneurysm, the goal is prevention of a rupture. So 4 centimeters, you're going to do a conservative treatment. They're just going to watch it. They're going to try to reduce the risk factors. Usually if it's 5 to 6 centimeters, they're going to do surgical repair. You want to assess for any other comorbid conditions. Anything that can hinder their treatment or hinder any kind of surgical treatment. So pre-op care, you're going to get labs. You're going to give them IV fluids. You're going to do an abdominal x-ray. You're going to prep them for surgery, and you're going to teach them about the surgical procedure. Now, surgical repair is going to basically be incising the diseased segment of the aorta, removing any thrombus or plaque. Usually they're going to insert a synthetic graft, and they're going to suture that to the normal aorta, proximal and distal to the aneurysm. Now, suturing, what they're going to do is suture a native aortic wall around the graft as a protective cover. And this just kind of shows you what they do. this slide. Now, endovascular procedure is minimally invasive. It's a sutureless graft. It's done through the femoral artery. The benefits are decreased anesthesia time, less operative blood loss, decreased morbidity and mortality rates, small bilateral groin incisions, more rapid resumption of physical activity. They also have a decreased length of stay and quicker recovery time, and the cost reduction also. Now, complications from this are going to be your perigraft leak. It could dissect. The aorta could dissect. They could have bleeding. Also, the graft could dislocate. They could run into renal artery occlusion, graft thrombosis, incisional hematoma, or infection. So post-op care for a AAA, usually they're going to be in the ICU, usually on an ET tube or the vent. They're going to have an art line, maybe a Swan's Gans catheter to monitor pressures. They're usually going to have subclavian lines, so they're going to have like a central venous line. A Foley, NG, possibly chest tubes, might have an epidural PCA, pain pump. They're going to have continuing EKGs, monitoring of their vital signs, pulse ox, pain control. To check graft patency, they're going to maintain an adequate blood pressure. You're going to do hourly urine output. Probably going to have a CVP measurement. Hypotension can cause the graft to have a thrombus, and hypertension can cause graft leakage, so you want to maintain an adequate blood pressure. Cardiovascular, you're going to look for any kind of arrhythmias. You're going to be careful to watch for an MI or electrolyte, and you're going to monitor their electrolytes. So infection, you want to watch for their temperature, their white blood cells. You want to observe the wound. You want to do meticulous linen care, dressing changes, and Foley care. Also meticulous line care, so you want to make sure that they don't get any kind of blood infection. GI-wise, you want to look for any kind of paralytic ileus. You're going to have an NG tube inserted in them probably, and you want to try to get them up for early ambulation to promote their GI waking up. Neuro, you're going to assess for any kind of any problems with neuro, decreased level of consciousness, or anything going on with the neurological system. Peripheral perfusion, you're going to do this. You're going to check that by checking their pulses hourly. Renal function, you want to check their hourly urine output. You're also going to check their BUN and creatinine levels daily to see how well their kidneys are functioning. Now, discharge teaching, you want to teach them to gradually increase activity. They need to know that they're going to anticipate fatigue, probably a poor appetite, irregular bowel habits to begin with. You don't want them to do any kind of heavy lifting for 4 to 6 weeks. You want to teach them how to look for infection, any kind of incisional infection or fever, and to call their doctor if they have any of that going on. They're going to observe for any kind of complications, so any color or temperature change of the lower extremities. They need to learn how to check their pulses, and they're also going to have to be taught about possible any kind of sexual dysfunction because of the blood flow, the loss of blood flow to that areas. Now some review. So a client with arteriosclerosis asked the nurse which factors are responsible for this condition. What's the nurse's best response? A, injury to the arteries causes them to spasm, reducing blood flow to the extremities. B, excessive fats in your diet are stored in the lining of your arteries, causing them to constrict. C, a combination of platelets and fats accumulates, narrowing the artery and reducing blood flow. Or D, excessive sodium causes injury to the arteries, reducing blood flow and eventually causing obstruction. So the correct answer is C. Okay, the nurse is working with a client at the health fair. Which teaching takes priority to reduce the risk of arteriosclerosis? Is it A, instructing a diabetic client not to smoke or use any tobacco? B, teaching diet changes to the client with elevated cholesterol levels? C, suggesting limiting alcohol to the older client with hypolipidemia? Or D, encouraging exercise to an obese patient who lives in a sedentary lifestyle? So priority would be teaching the diabetic client not to smoke or use any tobacco. Okay, a client with hypercholesteremia and arteriosclerosis is prescribed Aneursym. Which instruction does the nurse provide to the client? A, this medication might make you flush. B, take this medication on an empty stomach. C, you may not need to change your diet. You will not need to change your diet with this medication. Or D, take this medication when you experience chest pain. Okay, they need to make sure that they know that this medication might make them flush. Because of what? Because of vasodilation. Okay, the nurse is reviewing the menu selections of a client who's ordered a low cholesterol diet. What meal item does the nurse question? Would it be a vegetarian wrap, a cheesesteak sandwich, a fruit salad with yogurt, or a grilled fish sandwich? So it would be the cheesesteak sandwich. Okay. After reviewing the client's chart upon admission to the unit, the nurse consults the healthcare provider about a new order for lovastatin or Mevacor. What triggered the nurse's action? So after reviewing a client's chart, the nurse consults the healthcare provider about a new order. Is it going to be blood glucose of 182, a history of peptic ulcers, a history of high cholesterol, or elevated liver enzymes? Remember, it's a statin, so it's dealing with cholesterol, so it's going to be elevated liver enzymes. Okay. A client has been diagnosed with Cushing's syndrome. What assessment does the nurse perform to detect vascular complications with this illness? And I didn't go over that with you, so we'll skip through that. Okay. The nurse is assessing a client who reports claudication after walking a distance of 1 block. The nurse notes a painful ulceration on the 4th toe of the client's foot. What condition do these findings correlate with? Would it be a diabetic foot ulceration, a peripheral arterial disease, a peripheral venous disease, or a deep vein thrombosis? So if you chose peripheral arterial disease, you're correct. Okay, the nurse notes a venous ulceration on the client's left ankle. What additional assessments finding does the nurse expect for this client? Is it going to be absence of hair on the lower extremity? Is it going to be skin surrounding the ulcer molted, not blanchable? Is it going to be a brown discoloration of the lower extremity? Or is it going to be a cold and gray-blue lower extremity? So remember, venous ulceration, they're going to have brown discoloration of the lower extremity. Okay, the nurse is caring for a client with peripheral arterial disease. What priority nursing intervention does the nurse perform to promote vasodilation? Is it going to increase the client's exercise regime, apply a heating pad to the affected limb, administer an aspirin on a daily basis, or educate the client to abstain from smoking? So the best intervention is going to be to educate the client to abstain from smoking. Okay? The nurse assesses a client's legs, which assessment indicates arterial insufficiency. Is it going to be ankle discoloration and pitting edema? Is it going to be dependent molting and absence of hair? Is it going to be pain with activity but not while resting? Or is it going to be full veins present in the dependent extremity? Okay, so it's going to be B, dependent molting and absence of hair. Okay, the nurse is assessing for skin care changes in an African American client admitted with peripheral arterial disease. What does the nurse monitor for? Okay, it's going to be excessive hair growth, pitting edema in the feet, a loss of toenails, or cyanosis of the nail beds. Okay, African American descent, you're going to look for cyanosis in the nail beds. Okay, the health care provider has prescribed a client sodium warfarin or Coumadin while he's still receiving intravenous heparin. Which is the nurse's best action? Would it be to administer both heparin and warfarin as prescribed? Is it to turn off the heparin before administering the warfarin? Is it to clarify the warfarin order with the nursing supervisor, or is it to hold the warfarin dose until the heparin is discontinued? Okay, correct answer is A, administer both heparin and warfarin as described. Because how long does it take the warfarin to get into your system? Several days, okay, so to get to a therapeutic level, so it's okay to administer both. The nurse is providing disease management education to a client with Raynaud's disease. Which intervention does the nurse suggest to prevent complications of this disease? Is it A, take vasoconstrictive agents when you have symptoms? Is it B, wear warm clothing when exposed to cool temperatures? Is it C, avoid placing alcohol-based lotion on affected extremities? Or is it D, check the strength of your pulses in your arms and legs daily? Remember, you want to prevent complications, so you're going to wear warm clothing when exposed to cool temperatures. Okay, the nurse is assessing the extremities of clients with Berger's disease. What clinical manifestation does the nurse correlate with this disease? Would it be reddened with diminished distal pulses? Would it be cold and pale with a proximal bounding pulse? Would it be cyanotic with decreased deep tendon reflexes, or brownish discoloration with pitting edema? So if you chose reddened with diminished distal pulses, you were correct. And that's it for my integrity on cardiovascular alterations.